it's 7:33. We will get started. Good evening, all of you, to this 40th episode of the Weekly Huddle. It's about 10 months ago when we started this weekly casual discussion. At that time, we didn't know how far we are going to come along. So it's been about 10 months now, and we hope that we are going to continue at least for some more time, if not past 1 year. Most of you know me. My name is Anup. I am a cardiologist at CARE. And in today's session, I am joined by my colleague and co-host, Dr. Pulmonary. The huddle is an unscripted audience level interaction where we address common clinical scenarios and we discuss regarding the management strategies or the guidelines or the science behind it. We aim to keep the discussion patient practice oriented, and we typically pick up a topic and we keep our discussion around that. The basic premise is to bring our casual discussion to a more organized platform like this one and share our ideas. While we do welcome science and guidelines, what we intend to do is help a physician translate established knowledge to common clinical practice, taking local factors and practice patterns into account. And that is the purpose of today's discussion as well. The topic that I have chosen today is something which we see very commonly. And my basic aim is to revise some of the standard of care that we practice, not necessarily the standard of care which are written in the textbooks, because many of the times we have to modify it based upon what our local requirements are. So I'll be interested in knowing what you are doing in your clinical practice, and to understand the rationale behind why you do that particular thing. So having said that, I will start with the clinical case and I will invite Dr. Praneeth to give his input first. And after that, I will open it for discussion for anybody else who wants to weigh into this. So typically what I do is I put up the case completely and then I'll ask Praneeth to share his opinion. This time I'm going to go stepwise, where I will ask him one point at a time so that we don't get too much confused while doing so. So Praneeth, I'm going to ask 5 questions for this particular patient. I will go one by one. So let me start with this. This is a 46-year-old male. He presented to my OPD last week with dyspnea, which he was having for the past 1 week. This dyspnea is at rest as well as on exertion. And this symptom was also associated with painful left leg swelling, which is also happening for about a week now. He is a long-haul truck driver by profession. He works in Bangalore. He had a unilateral DVT 8 years back, which at that time people told him was because of his work. He was told to modify his work at that time. He was put on anticoagulant, which he was not very compliant with. And later on, he developed chronic DVT and he had some varicosities, which he was living with so far. He had some vague pain on the left side, but otherwise he was leading a usual life. He took a flight to come to Hyderabad about 10 days ago to meet family. And in the last 7 days, he had been complaining of this symptom. So he's a visitor to our city. He does not have any other complaints. While I examined him, his left leg is swollen. It is tender. There is no any obvious erythema or any signs of cellulitis, as to speak. His systolic BP in the OPD was 80. I could not get his diastolic blood pressure. His heart rate was about 104 to 108. He was maintaining saturation of 99 at room air. Rest of the examination was fine. His routine labs, which he brought with him, was okay. I ordered an ultrasound of his leg, which was suggestive of unilateral acute on chronic DVT of the side involving up to superficial femoral vein. CT angiography of the thorax was ordered, which revealed filling defects involving both segmental branches of the pulmonary arteries, right more than the left, suggestive of acute multi-segment pulmonary thromboembolism. His ECG was showing sinus tachycardia with non-specific ST changes. Echocardiogram suggested dilated right ventricle with preserved systolic function. He had very real tricuspid regurgitation and we couldn't calculate accurate right ventricular systolic pressure. His rest of the echocardiogram was normal. So we diagnosed him as massive obstructive acute pulmonary embolism given his hypertension and RV strain. We plan to thrombolize him, put him in ICU, and continue with other supportive treatment. So that is the overall idea of this patient. So this patient is in the emergency. So Praneeth, I'm going to go one by one, and then I'll ask your opinion, and then we'll open it for discussion. So if you could unmute yourself. Here is my question to you. Number one, thrombolizing an acute pulmonary thromboembolic patient, which drug do you prefer, and do you prefer bolus versus infusion? We are talking about a large thrombus burden disease like DVT, pulmonary embolism, stuck valve, those kind of diseases, as compared to a small thrombus burden disease like acute MI or stroke. So in this case, we are talking about pulmonary embolism. What is your drug of choice, and bolus versus infusion? Praneeth.
Currently, I would prefer giving tenecteplase.
Okay, so tenecteplase you give. So again, for the audience, the typical dosing regimen is 40 milligrams bolus dose for an acute MI, and then you go 5 milligrams here and there based upon the patient's weight. So something like if a 50 kg person comes with acute MI, then you probably are going to give 30 or 35 milligrams of tenecteplase, versus if it's a 100 kg person, then you're probably going to give about 50-55 milligrams of tenecteplase. But standard is 40 milligrams tenecteplase for acute MI. Praneeth, for pulmonary thromboembolism, what is your dose?
Same dose.
Same dose. And do you give bolus or you give infusion of tenecteplase?
Bolus.
Bolus, okay. And I'm sure you are aware that tenecteplase is not approved for pulmonary thromboembolism.
Yes, yes.
And so defend yourself. Why tenecteplase? Why not some other thrombolytic agent?
So with the patient already having hypotension, I doubt I have problem with streptokinase producing hypotension with the drug itself. So yes, it is approved. So I would prefer giving tenecteplase, which does not have the side effects of hypotension associated with STK, and giving tenecteplase, which is easy as a bolus and all. And my experience with altiplase is limited.
Okay, so because that was my follow-up question, why not altiplase? So you're saying because your personal experience with tenecteplase is far more than your altiplase. Because I think the comfort level is very much there, because tenecteplase becomes the standard drug for acute MI. So the comfort level certainly adds up. Then the second question comes, Praneeth, you have given thrombolysis. Now, what anticoagulant you are going to choose? Particularly, I'm asking about unfractionated heparin bolus and infusion versus low molecular weight heparin in twice subcutaneous dosing, or you start novel anticoagulant right up front. What do you prefer in these patients?
I would prefer to give unfractionated heparin bolus followed by infusion, particularly when I'm combining with thrombolytic therapy, because in case if there is any bleeding issue or anything, I have a control on the anticoagulant, where one, the duration of the anticoagulant effect is a bit short lasting, and equally I have an antidote make reverse the anticoagulant effect in case if it's a major catastrophe.
Okay, then the follow-up question is, when do you switch from heparin to a longer acting drug like Novac or warfarin or something of that sort? I did not put warfarin here because I think each one of us have kind of got away from warfarin in these situations.
Usually after maybe 24, at least 48 to 72 hours, by the time patient is relatively stable and the got out of the acute situation, and when I am in a position to transit patient from ICU to room, that is the point when I will make this transition.
Okay, the third question that I have in the same series is, what is your criteria for discharging these patients?
Criteria for discharging is clinical stability, where there is no tachycardia, there is no tachypnea, and I would ask him to do kind of a walk in the corridor, ask him to do make an independent, make him move independently, make some walk in the corridor and see how he is doing. If he does not have any exertional dyspnea, no drop in saturation, and is reasonably okay, that will be my call for discharge.
So essentially what you are saying is you do a poor man's 6 minutes walk test on this patient.
Right, right.
And this patient has to pass that 6-minute walk test, both in terms of symptom, in terms of saturation, blood pressure, and whatnot.
Correct.
Is that right? Okay. Now, this patient is a visitor to Hyderabad. He actually asked me on the day of discharge, doctor, when I can fly back to Bangalore?
Yeah. So that I would ask him to come back for a week's review. I would ask him to preferably stay back in Hyderabad. If he has relatives, stay in a relative's house, or I would request him to stay in one of the nearby hotels or lodges and wait for a week's time and to reassess him. Again, do the same assessment kind of a thing in this 1 week's time. Make sure that you are independent, able to manage yourself, not much of dyspnea, day-to-day activities, not produce any difficulty, and do an echo and ECG after a week's time. Look for his RV function and RV systolic pressure, and then probably take a call on clearing him for travel.
Okay. And then the last question is, he is a truck driver. He's going to ask you, when can I resume my work once I go back to Bangalore?
So I doubt whether that profession itself is producing his recurrent DVT and all the current DVT and PTE. I would what do you call doubt that he might be having a procoagulant condition which is actually producing, or he is a drug incompliant in terms of taking proper prophylaxis. First, I would be tempted to make these changes, because changing profession is really tough, and it puts a lot of toll on the livelihood of the entire family. So I would first encouraging him to be compliant with the drugs and use stockings and correcting dehydration and all those things. And yes, I would hint him to try to look for an option, but relatively not pushing aggressively on changing. And if we have to clear him for going back to work, I would say after a week's time, then he will be good to start his work.
So essentially, after a week, if he sees you and if you find he's okay, he can go back to Bangalore and he can resume his work, if I'm reading correctly.
Yes, yes.
Okay, perfect. All right. So Praneeth, that was in series the few questions that I wanted to get your impression, because these are not groundbreaking things. These are very routine standard of care. Every pulmonary thromboembolism, these questions will come to us at some point of time. And there is one question in the chat box as well, which I will get to. But let me get other attendees' opinion in this. If you joined late in the huddle, may I request you to please go into the chat box and just read through the clinical case. I'm going to post it again so that people who joined late, they can read through it. We are discussing a clinical case of a 46-year-old male who is admitted with acute pulmonary thromboembolism, which is massive. And we are trying to figure out what should be the standard of care for this particular patient. And I'll keep posting this case again and again in the chat box so that people who join later, they should be able to see. If you have any comments, please raise your hands or unmute yourself. I'll keep going through the list and asking opinion from others. Dr. Shankar is joining us. Dr. Shankar is a senior physician with us. Dr. Shankar, if I may get your opinion, I'm not going to go through individual scenarios because I already discussed it with Praneeth. If you could comment on each of these in terms of what will be your overview in taking care of patients like these. We are talking about management. Dr. Shankar.
Well, good evening to all. Especially in this case of a massive pulmonary embolism, a 46-year-old male, I would start with the thrombolytic therapy. Earlier, we used to give urokinase 4400 international units per kg as a loading dose, and that was gone. And after the advent of this recombinant TPAs, you are switching on to this RTPA. But I prefer altiplase or retaplase in place of tenecteplase, where this is not approved in the guidelines. So I give RTPA, altiplase or retaplase. First, I give 10 milligrams IV bolus within 1 to 2 minutes, then followed by 50 milligrams in 1 hour IV infusion, followed by 40 milligrams next 2 hours. I give a total of 100 milligrams. This is, I am audible?
Yes, sir. Yes, sir, you are audible.
So I prefer, because I don't have any experience with the tenecteplase other than myocardial infarction and even in acute strokes also. But I don't have experience regarding tenecteplase in pulmonary embolism. I prefer altiplase or retaplase in this situation. I give bolus as well as infusion.
And sir, how about anticoagulant? Which one do you choose? You choose heparin or low molecular?
Anticoagulant I use, see, after this thrombolytic therapy, within 3 hours, we can start low molecular weight heparin. We need not go for unfractionated heparin. I go for enoxaparin or the dalteparin. Give for 7 to 10 days, I give. So in between also, I can stop low molecular weight heparin and put him on Novax or Dovax, the rivaroxaban or apixaban.
And sir, do you think he will be okay to fly in the next week or two, or you typically tell them to wait longer?
Once he is taking oral medication, and as the house opines, the 6-minute walk test is a gold standard, and if he is able to do, then he should take so many precautions. As at the time of discharge, we should write all these things regarding. He should inform the airport authorities. Then he should take a minimum 2 to 4 hours before the air travel, the low molecular weight heparin. Though he is on oral anticoagulation, he should take low molecular weight heparin 1 milligram per kg body weight 4 hours before the travel, air travel, and he should inform the authorities to provide him an aisle seat rather than a window seat, because he can walk around and he can get up and easily and walk around. And in the flight also, you should do some exercises regarding the ankle, rotating the ankles and the dorsiflexion of the foot and all calf exercises. And you should hydrate, preferably he should hydrate more. You should avoid alcohol. Then preferably he had DVT. That's why he has to go for graduated this elastic compression stockings if they are available. He should definitely he should wear these stockings. These precautions he should take while traveling in the flight.
And sir, the last question, what do you think about his fitness to go back to work?
I regularly, actually, I advise the rehabilitation, cardiac rehabilitation in these individuals before going to work, even before flying also, because there will be a lot of anxiety will be there. Once if any patient of pulmonary embolism we encounter, how much anxiety he will have, we can find out. He will be very, he will be afraid of going to the work also. And see, I advise in between cardiac rehabilitation has to be taken, so that he will be accustomed to this walking, some amount of exercise and all. Then he can go to work. At least I prefer him not to go to work for 1 month. If possible, 3 months.
Thank you so much, Dr. Shankar, for that comprehensive thought sharing. I will defend in terms of why I chose these questions in particular. And Dr. Shankar, I'm going to mute you. I'll just share my thought for the next 2 minutes. So number one is because tenecteplase versus other thrombolysis is a topic of discussion, because tenecteplase is, while not approved, it is one of the safest drugs that we know for acute MI, and rightfully so. Its use is extended to large thrombus burden diseases like pulmonary thromboembolism. So that's something worth discussing. And somebody put up a question: what is the legal ramifications of using an off-label drug? And that, I think, is an equally important thing to talk about. Second thing is, with this NOVAC, how soon can we start it, whether we need to wait for a week or so, which has been discussion. And the dosing regimen of NOVACs are also different, and that is also something which I will probably discuss with one of the attendees about how do we dose these NOVACs early on. And then the fitness to fly is very important, because as we know that while our modern airplanes are pressurized, they are pressurized as you will have an oxygen pressure at 8,000 or 9,000 feet. And that is what they are advised to do. A lot of aircraft, in the aim of saving their aircraft longevity, may pressurize it for 10,000, 11,000 feet. So it's almost like a person with acute pulmonary embolism going on a mountain hike immediately post pulmonary embolism. So now we are talking about these patients going in an airplane for an hour or two, or maybe longer, where the partial pressure of oxygen is almost 60–70% that of what they will get on the ground. And a lot of us will become very uncomfortable if those patients say, I'm going to go and live in Missouri for some time. And truly speaking, in the airplane, they are getting an air concentration similar to that. So that flying is really important for us to address, because pulmonary embolism is very specifically related to flying as compared to acute MI or stroke, or for that matter, other diseases where it may not matter that much. And then fitness to work is equally important, because somebody asked whether driving is a risk factor for DVT. Driving as a profession is not necessarily a risk factor for DVT, but I consider patients who are on long haul driving job, like long truck drivers, those people who take an overnight journey in the truck where they don't have much movement, and essentially they have stasis of the blood flow in their legs. So in my opinion, those are risk factor for DVT. And now you're talking about these patients with massive pulmonary embolism, first of all, going for a high intensity work. That in itself, whether it is advisable to go for the work or do cardiac rehab, what Dr. Shankar said, and then go for work. And secondly, is it okay to go back to a work which is going to predispose them for more DVT, as to speak? So those were my reasoning of why I thought these questions are worth discussing. So while I choose my attendees to share their thoughts, if anybody has any other questions or comments, please speak up, or you can raise your hand. And while you gather your thought, may I ask Dr. Raghu to share his thought? Dr. Raghu is a senior cardiologist at CARE. I'm sure he doesn't need any introduction for these attendees. Dr. Raghu, I hope you were able to get the clinical case that we are discussing. And if you could share your thoughts on how you would manage. Dr. Raghu, if you can hear me, could you please unmute yourself and share your thoughts? Okay, maybe there is some technical issue. Dr. Gopi Krishna, you are unmuted. Do you have something to add?
No. No.
Yes, Dr. Raghu. Yes, we can hear you.
I'm actually
Yes, sir.
enjoying the dinner and also the scientific content. So I think I'll abstain from talking and only listen and enjoy myself. I'm in the club actually,
Sure.
so if
Absolutely,
I
sir.
talk, it will create a problem here.
Sure. Sure, sir. Absolutely. Dr. Gopi Krishna, do you have something to add? You are unmuted briefly. Okay, if not, let me move ahead. Dr. Prithvi, you are here since the first minute that we opened today's discussion. If you could please unmute yourself, share your thoughts about what we are discussing, how you practice in your location, patient with massive pulmonary thromboembolism. Dr. Prithvi, if you could unmute yourself and share your thoughts.
Good evening, sir. So in our center also, I will thrombolize with tenecteplase, sir. So I have a good experience with tenecteplase, and after initial thrombolysis, I also start low molecular weight heparin after half an hour or 1 hour. So and I will continue it at least for 5 days. So then I will switch over to Novax, sir. Then regarding the work when I will assume, I also advise him for 6 minutes walk test for after initial 1 to 2 days after observation in ICU when shifting to room, and then with the clinical symptoms and signs like tachycardia settle downs and tachypnea settle downs. Then regarding air travel, I'll ask them to go at least after 1 month. At least for a month, I will deny it actually. And regarding resuming the work, similar, sir. At least 1 month, I will ask them to hold, sir.
Perfect. Thank you. Thank you so much. Yeah. Thank you so
Okay.
much, Dr. Prithvi. Let me see who else. Dr. Prashant is here with us. Dr. Prashant Vazirani, if you could unmute yourself and share your thoughts about how you would manage this patient, how do you typically do, and your advice to the patient.
Hello, good evening, sir.
Yeah, Prashant.
Sir, yeah, I wanted to just ask that this patient has been written that he has been traveling, and then after that he has been diagnosed at pulmonary embolism and maybe a repeat PT. We had a chronic VT and then now pulmonary embolism. But if you go theoretically, if you go through the list of provoked conditions for VT, air travel, if only more than 12 hours is actually considered as a risk factor. And no doubt, I will also thrombolize with tenecteplase only. In care also, we have been thrombolizing with tenecteplase. We never had an issue. Here also, I am at my region also using tenecteplase and STK in unaffordable patients. But tenecteplase always can have an issue, and I have one colleague who is facing the same issue. That is why I asked that question. So yes, I am using tenecteplase, and within 3 to 6 hours, we start them on unfractionated heparin. We don't use much of low molecular weight heparin. For 72 hours, we keep them on unfractionated heparin, and then we switch them directly on NOAC or a warfarin. We still use warfarin as patients, not all the patients can afford this, and then they stop, so it creates an issue. And NOACs, as we know, they do not require any overlap, so it is easy to directly switch the patient on NOAC. Most likely, rivaroxaban 15 milligrams twice a day for 3 weeks, and then 20 milligrams once a day is routinely what we follow. And also, if for traveling Hyderabad, he wants to go to Bangalore, I think, and that is only a 1 hour flight. So that should not be an issue, because only long flights have an issue. Always pressure is a issue. But this Hyderabad to Bangalore is only 1 hour flight. So I don't think there should be any issue if he is following what Dr. Praneeth sir is saying. If his lung functions, what we are assessing is okay. And for resuming work, I will at 3 weeks, I will see him and I'll do his D-dimer levels and other routine tests. And if the D-dimer has come to normal, I don't think that any issue is there. But obviously, if he's a driver, then his long traveling hours should be restricted. That is also.
Perfect. Perfect, Dr. Prashant. Thank you so much. You did bring up a few points here. So, you know, I did put in the flight and everything when he came from Bangalore to Hyderabad, not particularly to emphasized that that flight was the risk factor for recurrent DVT. I was just narrating the entire story, but I agree with you, 1 hour flight should not trigger a DVT. It is more of, in my opinion, a patient who is already predisposed to a DVT before, non-compliant before, has chronic DVT, and you know they all become risk factor for recurrence. So I think that he just has a recurrence. It just happened to be in Hyderabad rather than Bangalore. I don't particularly think, as you said, that whether that 1 hour flight will cause predisposition. The question about the return flight is, and that is where, while duration is important, what is also important is how is he going to tolerate 35,000 feet flight where the air will be pressurized for 10,000 feet. Remember, your partial pressure of oxygen at the ground level, if you check ABG in a normal person, if it comes around 100 at room air, if you check an ABG in a person who is in the aircraft, that ABG will come with a partial pressure of maybe 75 or so, or 80 or so. And that is normal, because that will drop that person's saturation to 90-92. And you know, with the oxygen dissociation curve, that's all right. The problem happens when the partial pressure of oxygen in the blood drops below 60 or 65. That is where your saturation starts dropping very fast. So in these patients with acute pulmonary thromboembolism who are just recovering from it, how are they going to react when their ambient oxygen level goes down? Whether they will react in a similar fashion to the partial pressure. That is something which is challenging to estimate. Now, can you do a situation where you can simulate 8,000 feet flying on the ground, and if the patient passes that test, then you can clear him for flying? I think that will be quite interesting to do, because remember, if you discharge a patient with a saturation of 92, 93, which is quite accepted, you don't know whether his PO2 in the blood, whether it is 85, 90, or whether it is 75, 76. If his resting PO2 is 75, 76, which on the ground is very much okay, when he flies, his PO2 may drop to 60 or 55, and that will be a problem for him. So that is the whole idea of why even a short duration flight, till the time he's taking the commercial airliner where it is pressurized only to 8,000, 10,000 feet, not at the ground level, whether that is important or not. So anyway, we are going to continue our discussion. Let me ask, and before I ask my other attendee, my next attendee for his opinion, Prashant, I wanted to understand, you said something about tenecteplase and some of your colleague getting in trouble. If you don't mind just very briefly sharing what happened. Was somebody questioning his use of tenecteplase in pulmonary thromboembolism?
No, sir, actually it was a massive pulmonary embolism, and my colleague, who is also a cardiologist, lives in different city, and that patient unfortunately had a fatal outcome even after thrombolizing, and then relatives had done a case against the hospital, so now that matter is judicial. So he was asking me like tenecteplase on paper, like if the non-medical people who are dealing with these things, the court and the lawyers and all, they will just ask for evidence that what are drugs you have used, so what should I produce? So I was also thinking that yes, on papers officially everywhere it will be written that it is not approved. So maybe if there can be an issue or not, I don't know. That his thing is also in court. There has not been any judgment till now, but that is why I put up that question.
But that has not been asked by any lawyer yet, right? Nobody questioned that yet.
No,
Is
but
that correct?
he was asked that what drugs you have used and what is their indications and whether they're approved drugs, what is the bleeding, and all that was asked by the lawyers. So he was asking like, what should I give? Because tenecteplase actually we have used, but it is not approved. So should I put that point? So I told that just put a list of drugs which we are using and their indications, and just don't bring that point that it is not approved into the eye, because that can create an issue anytime.
Perfect. Thank you so much, Prashant, for bringing it up. I think it certainly puts an insight on what we are doing, and kind of forces us to think what we are getting into. Let me continue our discussion. I'm going to seek more opinion. Let me see, Dr. Gopi Krishna, if I could invite you and get your thought process. You work in Nizamabad, which of course, you know, when we talk about the amount of resources that are available around us, then maybe to a certain degree in Nizamabad, you may not have that kind of resources that cities like Delhi or Mumbai or Hyderabad can have. Dr. Gopikrishna, a patient like this comes to your hospital. How do you deal with this on the points that we discussed about? If you could please unmute yourself and share your thoughts.
Practicing in Nizamabad is also almost like a same thing in such type of cases, sir. Actually, we do routinely. I'm usually thrombolizing with tenecteplase, and as far as my knowledge, till now, whatever the cases I thrombolized, except one case which I lost in thrombolysis, which is secondary to the massive bleed. Actually, loss of sudden gush of bleed from GI tract and hypotension, and we could not save the patient due to that complication. Otherwise, most of the patients, they recovered, and post treatment with the tenecteplase, they are doing well. So previously, I used to do thrombolysis with the streptokinase, but nowadays I'm using the tenecteplase. Regarding the oral anticoagulant, same after treating with the unfractionated heparin infusion for 1 or 2 days, adding the treatment with oral coagulants, and after confirming he's clinically stable by 6-minute walk test and check echocardiogram and clinical parameters, we are discharging them in a stable condition. And one of the patient I come across that he wants to travel to USA again because he works there. Then I advise them to take rest for 4 weeks and get a permission from their office. After 1 week, after checking everything and after assessing his functional capacity, then we again a permission to travel to the USA.
And Dr. Gopikrishna, just I want to follow up one question. When you give tenecteplase, what dose are you using?
So that depends on the body weight, sir. And
give me an idea.
Hello.
Yeah. Are you able to hear me, Dr. Gopikrishna?
Hello.
Dr. Gopikrishna, are you able to hear me? Okay, we have some technical difficulty reaching to Dr. Gopikrishna. Let me continue my discussion. Dr. Gopikrishna, I don't think we can hear you. Praneeth, I am audible, right?
Yes, Anup, you are audible.
All right, I just wanted to make sure my network is not having any problem. Okay, all right. While my attendees get their thoughts aligned and Dr. Gopikrishna has more to share, I'm just going to read a few of the questions. One of the questions that Dr. Rahul asked is this a recurrent PTE? Can we do anything more? So this particular patient, this is the first event of pulmonary thromboembolism. DVT is recurrent, but the pulmonary thromboembolism is the first patient, first event. Then the second question is, would like to know choice of patients for catheter-directed therapy versus systemic thrombolysis. So I'll tell you what I practice. I do systemic thrombolysis because of the very simple reason that catheter-directed therapies, I don't have it readily available. So it is the limitation in resource as well as the expertise. And by expertise, I mean that we don't do these cases that frequently. So I don't think I would consider people around me as or myself as an expert in this therapy. We know how to do it, but for us to call ourselves an expert, we should be doing it far more frequently. And as you know, these patients who are hemodynamically unstable, if you don't have a particular expertise in a therapy, then the outcomes you can't expect at a similar line as what you see in the research paper. Then one of the question is experience of thrombolysis in submassive PE. So in submassive pulmonary embolism, the guidelines suggest that you manage with anticoagulation alone. and you can risk stratify them to choose thrombolysis versus no thrombolysis. And risk stratification means that you observe them over time, and if they are diving into a shock-like state, or if they're not improving, or if they are showing new signs of strain, like person who did not have a right ventricular compromise before, but now is developing compromise with a positive biomarkers and all those things. If they are evolving in the wrong direction, then you can choose to thrombolyze those patients, although the science in that is not very clear. In fact, those are the patients where catheter-directed thrombolysis is far better option than a systemic thrombolysis, because they are not massive yet, and you are able to probably save some of this. So that's the scientific answer to it. In our clinical setup, as I said, that because of lack of optimal resources at the treatment point, there is a little bit of hesitancy. I do know of centers in India where they take up catheter-directed thrombolysis as the first-line therapy, because that's what they are doing, and because they have the relevant expertise around, they get good results with that. So those were the questions on the chat box. Let me ask one more opinion, and then I'll go to Dr. Somaraju. For some reason, Dr. Chandramukhi's connection is weak. She keeps popping up and then disconnecting. Anybody else has got any other questions, comments, or any thoughts before I go to Dr. Somaraju? Praneeth, let me ask your opinion. This question has been brought by Prashant. You are giving tenecteplase to your patients. How do you justify any of these cases goes to the court? You are using an off-label drug. You are using a good drug, nonetheless. It's a good drug, but you are using it off-label. How do you justify?
Strictly speaking, so far I did not put a thought to it, but yes, definitely it's a trouble if you are put into a corner. But so far it, based on the experience, or the, as you said, the experience of treating MIs and previous experience, you are able to do it. But yes, if you ask to justify, I don't have any answer.
And how about tenecteplase infusion?
I
Hello?
don't know. I haven't done any time. I haven't heard about it, so I can't comment on that.
Okay,
Anup,
Dr.
can I
Raghu, you are
something about?
okay. Yes.
Yeah. No,
Yes, sir, please
I
go
was
ahead.
just making a mention about this tenecteplase thing. I've used it so far in about 6 to 8 patients with very, very good results. In 2 of them, they were almost, they had cardiac arrest and they were revived and they had tenecteplase, and they immediately, the thrombus resolved and they're doing well. They come regularly for follow-up. Now, raising the legal point of it, I can always fall back and say that at that particular point of time, I had nothing but tenecteplase in the hospital, so I used it. I'm sure there are no records most of the time of what the pharmacy has and what the pharmacy doesn't. So in our country, where the accountability is much lower and you're doing it with good intentions, I'm sure you'll get away with it. The second thing is, as far as Altiplase is concerned, I've used that also earlier before the ease of administration of tenecteplase was available. And in those days, we used to give it as an initial bolus of about 15 milligrams, and then the rest of the 85 milligrams as an infusion over a period of 1 hour's time, starting heparin almost immediately and continuing unfractionated heparin at least for 2 to 3 days. Things are changing most of the time now. People are switching over to Novak as soon as 48 hours are over. But personally, I think here you cannot generalize. You need to take each individual patient up. After the patient comes out of the acute event, you still need to find out how much is the thrombus burden that's left behind, how much is the lung compromise, has the patient made a full recovery, or he still continues to be hypoxemic at rest. Then you must also have to look at whether the patient continues to have DVT. Is there residual DVT? Is there a likelihood of his having further embolic episodes? And in such situations, I think the need for an IVC filter in highly selected cases may come in, at least to temporize the situation, at least non-permanent IVC filter. So the management of a patient who's been rescued, who comes out, will again depend. There's a spectrum. It all depends on how full a recovery the patient has made. Sometimes I even resort to a perfusion scan to see what is the extent of lung damage that has happened. So these are some of my thoughts on this issue. Thank you very much for hearing me out.
Raghu sir, before you step out, quick question: dose of tenecteplase?
The dose of tenecteplase is 40 milligrams. I have used it only as an IV bolus most of the time.
Perfect. Thank you so much, sir.
I have never used tenecteplase. I have had recourse to the use of tenecteplase by other institutes. I have seen their discharge summaries, and most of the time they have used it in acute MI, much less in pulmonary embolism. Currently, I think in many centers, as far as I know, people are resorting to tenecteplase simply because of the ease of administration and the rapidity of action of the. Again, I would like to add in a caveat. For example, if the patient has come with an acute massive pulmonary thromboembolism of a very fresh event within 48 hours, then possibly tenecteplase is far better. But suppose he comes 7 to 8 days later, and it's cumulative episodes of pulmonary embolism, then a longer infusion like alteplase possibly works better. These are all, I mean, nothing like any of this is written down. People only talk, even the guidelines talk only about thrombolytic therapy versus catheter therapy, but not how much, what, and at what phase of pulmonary embolism a particular agent should be used.
Perfect. Thank you so much, sir. Prashant, you have a question?
Yes, sir. Regarding this tenecteplase infusion, I have used it several times when I was there in care also, and I always had this question after coming here also that whenever I talk to these TNK guys, they also told that no, infusion is not made for the TNK is not made for infusion, because if you read the package which comes with the insert which comes with the TNK also, it is written that it has to be used within 8 hours. And immediately after reconstitute, if you have not used, then you have to refrigerate it, and only after that till 8 hours you can use it. So once we reconstitute, we are giving it as an infusion for 12 hours or 20 hours, or we don't know till 24 hours. How much effective the drug will be remain actually after 8 hours, we don't know. Whatever the pharma guys I talked to, they told that no, preferably because it has been written and it has been told that it has to be used within 8 hours, so better not to use it as an infusion.
Thank you, Prashant, for bringing that up. In fact, I heard the story that the shelf life of a reconstituted tenecteplase is only 60 minutes. It's only 1 hour rather than 8 hours. But yes, whether it is 8 or 1, the point is very well made that if you put these patients on infusion, then how do they behave? How does the drug behave? We don't know. Few things I do want to highlight before I move to Somaraju sir for his comments. So the issue of tenecteplase versus alteplase is going to continue, and I think tenecteplase, because of the ease and the safety, certainly pops up as one of the favored drug. I use tenecteplase so frequently with good results, but again, we need to start publishing data so that we can defend ourselves that this is a good drug. Second thing is about the affordability of Novak. So as a lot of you know that rivaroxaban now has been off patent in India. There has been a lot of companies which are making rivaroxaban, and the drug prices has come significantly down. The same thing goes for apixaban as well, although it is not marketed as heavily as rivaroxaban. Dabigatran already is at a very low price. So if you look at from the price standpoint, overall, the cost may not be that significantly different now. One has to understand that Novak dosing for the first 1 week to 3 weeks is higher than that of the standard dosing. So if I have to put the numbers right, for acute pulmonary embolism for the first 1 to 3 weeks, and you get to choose whether you put 1 week or 3 weeks, rivaroxaban you are giving 15 milligrams twice daily in as compared to 20 milligrams once daily. Apixaban you are giving 10 milligrams twice daily, and in certain subsets 7.5 milligrams twice daily as compared to the standard dose of 5 milligrams twice daily. Dabigatran still says 150 milligrams twice daily, so that dose is no different. But that is another something that one has to understand. The other thing is, if you look at the data set of the natural history of treated pulmonary thromboembolism, the hemodynamic compromise can occur up to 2.5 days of presentation. So many of the times it is advocated that we keep a short-acting anticoagulant for the first 2 to 2.5 days, so that in case if there is hemodynamic instability and if you want to do something else, at least you are not stuck with a long-acting anticoagulant. So there is a school of thought that it may be a good idea to continue short-acting heparin for the first 48 hours or even slightly longer, to make sure that there is no late hemodynamic decompensation for these patients. So that is equally important, at least if you go by certain school of thought. Other thing also to remember is that when to start novel anticoagulant, a lot of these trials which got the drugs approved, they waited for 1 to 2 weeks to start novel anticoagulant drugs. So now, as you know, in common practice, it spills over. So now we start NOVAC in the hospital itself. But most of the trials, if you look at, they did give heparin or low molecular weight heparin, some trials 1 week, some trials 2 weeks before they started NOVAC, of course, because they wanted their drug to look good. But how does that translate into clinical practice, where we tend to start NOVAC by day 2 or 3? That is also something we have to keep in mind when we put this, when we start these drugs. So I'm just telling you the science and the guidelines behind it. And of course, what we practice is based upon what we have around us and the practice limitations that we have. So having said that, we heard 7-8 comments. Let me invite Dr. Somaraju for his comments. Sir, you heard the 5 topics that we are talking about in the standard of care of pulmonary embolism management. If you could share your thoughts on how you manage these patients and what additional things that we missed in this discussion. Dr. Somaraju.
Anup, thank you for asking me. And I think most of you covered most of the issues that has to be done in this patient. I will only address some of the issues that raised by everybody. And also fundamentally, there is a repeated emphasis today on disease-centeredness and patient-centeredness and person-centeredness. And this patient is a truck driver. A truck driver has a pulmonary embolism. First requirement is to check whether he has a HIV problem. It's an extremely important issue, and I'll leave it to all of you to think about it. When somebody has an HIV, and you know the issues, the truck drivers and HIV infection frequency is almost 40% higher thromboembolic disease in them. I leave it there. And going beyond that, some of you, I noticed, were worrying about the approved versus non-approved drugs. The issues related to limitations of evidence-based medicine, the formalities related to FDA approval versus what really happens in real world. And any of you is interested, I will send some information on them, particularly Prashant. I think your friend who got into trouble, he has to have a discussion with this lawyer and judges and talk about evidence-based medicine, its limitations, and randomized clinical trials limitations, FDA approvals, and issues related to that, including the political issues, and then request for a wider meeting of these lawyers and judges with others around in the country who also can talk to them. I can participate in it if you want. And then the limitations of evidence-based medicine and issues related to that and FDA and all that, we can talk about it. And then what is important is when the patient failed to improve beyond a point is one issue, and the patient improved well is another issue. The patient failed to improve, catheter-based issues and other alternatives have to be considered aggressively. And I think I wanted to say something more, but I think I'll leave it at this, unless somebody has some specific issues. And unlike coronary thrombolysis, pulmonary embolism requires a continued ability to thrombolize. If the patient fails to improve, what are the issues? That is one issue is catheter-based therapy, and rare patient will even require surgery, and that has to be kept in mind. I'll leave it at this. I don't think I covered everything. If you have any specific issues, I'll answer.
Sir, thank you so much. I think that HIV point is so relevant. I feel so bad not checking HIV status on that patient. I completely agree with you. This is something we have been taught in our MBBS days, that when you have a so-called high risk profession for HIV and related diseases, I think that is something we certainly should. After this, I probably should make it even a standard. And I think that goes in with the theme of today's discussion, that, this should be standard of care that we provide, that when you have these kind of patients, we should be checking HIV status on this. The floor is open for anybody who has got any questions or comments about this topic, or if anybody has any question. Dr. Somaraju volunteered that if you have any questions, he'll be happy to answer on this topic. If anyone has any questions to Dr. Somaraju as well, please feel free to discuss that. If nobody has any questions, sir, I will ask you one question. You mentioned about bailout catheter-based therapies. I just want to get your insight about the ethics of it. I mean, if catheter-based therapies for pulmonary embolism are not the first line therapy in any center, let's say if it is not a first line therapy, then I don't think any operator in that center would be doing once or twice per year. He wouldn't be doing more than that, or she wouldn't be doing this procedure at a frequency more than once or twice a year if it is used only as a bailout therapy, which is fair, which is absolutely fine. My question to you is, sir, the ethics aspect of it. Do you think we should be attempting procedures where we do it once or twice a year? Because with that lack of expertise, how comfortable we are that our outcomes are going to be good. On the other hand, we are doing it for a rescue case. What is your thoughts on this? If you could, Dr. Somaraju.
I'll say it's not the first choice. But we had two patients while we were at care, and my colleagues had done it, and both the patients are living well and normal 5 years from now. And that's not the first choice, I agree. But in certain selected patients, that has to be done as a decision based by more than one of the members of the cardiology and cardiac surgery team, and decide on this and then make a decision. And I have at least two patients where we could save them, and it did well. And congratulations to some of my colleagues who were participants in all this. But that's not a routine.
Thank you so much, sir. Dr. Malindra Swami, you were unmuted. Do you have any questions or comments? Please unmute yourself and speak up. Sir, you are muted. If you could unmute yourself so that we can hear your thoughts. Yes, sir.
Hello, I'm Dr. Malindra Swami. Hello?
Sir, please go ahead. Yes, sir, please go ahead.
Have you any experience of COVID patients having pulmonary embolisms?
Yes, sir. In our hospital, we had at least a few patients. I myself have treated 2 patients with pulmonary embolism, and I know my critical care colleagues have treated far more than what I have. We did see patients with pulmonary embolism, yes.
Yes, sir. For them, oral anticoagulation lifelong, or just you have kept Novak for only 3 weeks and just stopped, sir?
So I don't think there is any scientific consensus or guideline for it, but most of us, we are going with a treatment duration of 6 months.
Yes,
for
sir.
the positive COVID who have got thrombotic issue, not particularly thromboembolism, there is actually some consensus to say that you can stop after 2-3 months as well, not for pulmonary embolism, but for other thrombotic diseases. But I think for our cases, for pulmonary embolism, we are continuing for 6 months, not lifelong. We are not continuing like lifelong.
Okay, sir. Thank you, sir. Thank you.
Raghu sir, your comments?
Yeah, I thought I'll just add that I had one patient who presented with, he had a angiogram for an abnormal ECG and chest pain 3 years earlier, and that was normal. He came back after 3 years saying that he was mildly uncomfortable and breathless on mild exertion. He denied having any history of fever, but he said that he was having a mild upper respiratory infection. And well, I worked him up and nothing to fit in. The echo showed a mild to moderate pH, and I was not happy with that, and I took him up for a transesophageal echo. And to my amazement, I found a large clot sitting on the right pulmonary artery, and I offered thrombolytic therapy, but he chose to because of financial government hospital, where he underwent a COVID, and they found that he was COVID positive. And after that, he had a pretty stormy course, but he made it, and I have to see him again. He's promised to come over. I contacted him, but I only wanted to add this to say that the problems of pulmonary embolism is very real in patients who've had the COVID infection, and any history of shortness of breath cannot be taken too lightly. Thank you.
Thank you so much for sharing that example. And once again, going back to the issue of catheter-based thrombolysis or catheter-based therapies, I'm sure a lot of the attendees here, they know about this, but this is for them, for people who are not aware of this. You know, just like we have acute MI program for primary, and you have acute stroke program for thrombolysis or catheter-based therapies. US and some of the other Western countries, they have a PERT program. It is called PERT or Pulmonary Embolism Response Team, where a set of cardiologists and similar members, they form a rapid response team, call themselves PERT team, which I believe was started in Mass General when Kenneth Rosenfield was one of the pioneers in this. And it was taken up by a lot of programs, including the hospital where I got trained in, where essentially you have a set of doctors who take it as a primary angioplasty, where a patient who comes in with massive pulmonary embolism, first line of treatment becomes a catheter therapy, which typically is a mechanopharmacologic therapy using devices like ECOS catheter. It's called EKOS, which is a radio frequency catheter. It oscillates at a very high frequency and it delivers thrombolysis right at the site of thrombus. It is FDA approved therapy, and the PERT program in those hospitals where they have been applied has certainly done very good in terms of clinical response and long-term outcome as well as functional outcome. And that is where my whole thought was, because in those programs, catheter-based thrombolysis becomes the first line therapy for massive pulmonary embolism. And there, over the time, the expertise and the response time and everything is pretty much put into the system to get a better outcome. So something like this exists in the world. I'm guessing it would be difficult to implement in our setup, particularly in Indian corporate setup, where programs like PERT is a more holistic multi-departmental response team as compared to an acute MI, where you don't require that much of collaboration. But this is again something which is happening in part of the world, and they do fantastic with it. Having said that, I'll come to the end of it. If anybody has got any questions or comments, please share for the next minute or so. Otherwise, we can close the session. Dr. Shankar?
Yes.
Sir,
I'm fortunate.
Yeah.
I'm very happy to participate in this discussion. I'm fortunate enough to have teachers like Dr. B. Somarazu, because still just before Corona, we used to have grand rounds with him. Dr. B.K. Shastri used to arrange in the care hospital. Myself and Dr. Professor Dakshinamurthy from Tenali, and other doctors from various parts of state and other states also used to attend the grand rounds in the care hospital, and we used to enjoy that academic feast with Dr. Somrazu. In this connection, he has shown in the grand rounds a case of a business executive from Nellore. Probably Dr. Somrazu sir might remember this case. A business executive from Nellore, he went to corporate hospital with shortness of breath, but he was undiagnosed. But he was not diagnosed there. He came back to care hospital with the subtle changes in the ECG. Dr. Somrazu, he showed how to suspect pulmonary embolism in this case, and how best we can treat if it is diagnosed earlier. With a high index of suspicion should be there, because pulmonary embolism is a challenging topic. Is a challenge. It is a challenge actually, because the patient comes with the non-specific symptoms like hemoptysis, chest pain, shortness of breath, some low-grade fever. So we should have a high index of suspicion, and we are fortunate to have teachers like Dr. Somrazu, who used to show the subtle changes in the ECG to suspect pulmonary embolism and how to proceed further with the D-dimer and CT angiography, and how best we can interfere, how best we can intervene in the line of management. Thanks, Dr. Somrazu sir, with us today in the discussion.
Thank you so much, Dr. Shankar, for sharing. Prashant, I'll come back to you. Dr. Raghu, you have anything to add?
Yeah, you mentioned catheter-based therapies, Anup. I thought you could have gone into the slightly more into the details of. I mean, catheters-based therapies are used in 3 or 4 different ways. One is mechanically trying to push the thrombus more distally, or using thrombolytic therapy to be delivered locally at the site of a large thrombus, or what they now have and they are preferentially using abroad is ultrasound-based destruction of the thrombus. These catheters, I believe, are very expensive and haven't still come to our country. They're using it in other centers, but I have not really had any opportunity of anybody having used and projected it in our country. So these some of the ways that catheter-based therapies can be used in overcoming pulmonary thromboembolism.
Thank you so much, sir. I, on purpose, did not mention the details because I wanted to keep the theme of the discussion being the standard of care. So I didn't want to get too much into the real, very niche aspect of it, because that may not interest people who are not actively involved in this. But thank you for bringing it up. At least it gives us an overview of what we do. Prashant, your last comment, and after that we'll be done.
No, sir, I just wanted to add to Dr. Swami what he was saying, to thank Somaraju sir for what he has taught us. Like when I had missed my first case of pulmonary embolism in an overnight duty, he came, he auscultated, and he told there is S2 split and he has a pulmonary embolism. You have missed it. Get a CT scan done. So that really helps in the practice whenever you want to take a decision of submassive PT patient, and I look for the split, and then we decide that he has RV dysfunction if an echo has not been done or wrongly reported. So that really helped us, and so I'm very thankful to sir for teaching us all that.
Thank you so much, Prashant. Somaraju sir, I don't think you would need to respond to those accolades, but in case if you do you want to share your thoughts? One last minute for this session.
I just want to tell you that I am not as good as all of them are trying to make me look like. I learned from all of them. I must tell you this.
Thank you so much, sir. Praneeth, your closing comments for today's discussion?
Yeah, so it's always good to interact, and nice to hear all the experiences which most of them shared. We really had a good discussion, thought-provoking one about looking beyond the diagnosis of what could be the reason for he having that problem, and probably digging down for the reason and getting to the core of the problem, and as said, trying to use what is comfortable, what you are used to, and not compromising on the safety, and getting the best of what is best of available care, and your ability is what I think is the way to go. So yes, practices change, but use what is what you're comfortable. That's what I could get from this discussion.
So much, Praneeth, and thank you all for attending today's session. To the attendees who are joining us for the first time, we would like to get your feedback for the session. If you found the session worthwhile, may we request you to share it amongst your colleagues, since the general motive is thought sharing, and more the merrier. We host this session every Wednesday at 7:30 p.m. The link that you click to join today's session, the link remains the same even for the future session as well. So in case if you don't get an invite for the next session, next Wednesday, 7:30, if you click that link, we will be right here talking about another topic. Thank you all. We do record these sessions, which pop up at podcast and YouTube. Once a while, I'm not very good at uploading all the episodes, but in the podcast, we have some 30 episodes uploaded so far. So if you need to go back in time and listen to some of those sessions, they should be available. I again thank you all for participating. I wish you good night, and hopefully I'll see you again next Wednesday. Thank you all. Good night.